In our setup, WHO has defined the definition of anemia, mild, moderate, severe, in different conditions. So there are cutoffs for that. For a man, if hemoglobin is less than 13, person is having anemia, that is mild. If it is less than 12, so it is moderate, and if it is less than 8, it is severe. Similarly, in pregnant women, the cutoffs are there, which we can go through. If it is less than 11, it is considered as anemia. There are a lot of nutrients are there where the role is there in erythropoiesis, and it has been discussed in previous presentation also that B12 and folic acid are very, very important. But if you see in erythropoiesis, vitamin A, folic acid, B12, riboflavin, B6, these all vitamins are important. At the same time, for intestinal obstruction, vitamin C is very important. Antioxidant function is there with vitamin E and C, so that is also. And similarly, for iron mobilization in the body, the vitamin A and C are important. So there are so many nutrients which are important for erythropoiesis. And along with that, we know that the kidney senses for the hypoxemia, low PO2, and with that there is release of erythropoietin by peritubular capillary linings, which is responsible for erythropoiesis. So this axis should also be normal. Bone marrow should be normal when you talk about good and healthy, hemostasis in the person's body. What are the adverse effects of anemia? We all know. So reduced physical development, decreased work output, work capacity, impaired sexual and reproductive development, low birth weight babies, and especially, the pregnancy-related deaths. 20%, in 20% cases, anemia is the direct cause of mortality in pregnancy, and in up to 50% cases, it is one of the major contributory factors. So that also has to be considered. For a physician's perspective, dividing anemia into, I think nutritional and non-nutritional anemia is more important, although we have so many other, types of, classifying anemia based on the size of the RBCs, inherited, acquired, and all. But in nutritional, iron deficiency anemia is the most common. We all know B12 and folic acid deficiency, we have to see, and then other micronutrients. And non-nutritional anemias, basically infections, hemolytic anemias as a group, acquired or inherited, anemia of organ failures, bone marrow failure, endocrine disorders, and chronic disease and malignancy. So we can divide, anemia like this, and we can approach in the similar fashion. So for any patients where we approach a patient with anemia, careful history is very important, especially about the nutritional, whether the patient is a vegan, predominantly vegetarian, or mixed diet, drug and alcohol intake, family history of anemia, especially for, hemolytic anemias, previous history of transfusions is very important. History of jaundice, history of gallstones, splenectomy, history of abdominal surgery is also important. And then history of bleeding, menses, melena, hemorrhoids, we have to ask specifically for that. And there are some ominous signs like fever, weight loss, night sweats. So this also has to be asked when you are dealing with a patient of anemia. Symptoms, we all know, fatigue, loss of stamina, exertional breathlessness, headache, giddiness. These are some of the pictures, very important. So glossy tongue without, tongue papilla. So this is evidence that maybe B12 or iron deficiency can be there. Hyperpigmentation of knuckles, very, very important. Cheilitis, angular cheilitis is there, esophageal web, brittle and spoon-shaped nails or flattened nails are a marker of iron deficiency anemia. So this is the case one. I will mainly discuss the cases in my presentation. So 27-year lady, gravida 4, P3, 6-month pregnancy, presenting with pallor, no history of blood loss or previous transfusion. She has severe pallor and no other significant finding. So first message is like, what investigation would you like to ask in this patient? What is the first investigation you would like to ask for this patient? So it should be basically a combination of this. So complete blood count, peripheral smear, as well as reticular count. So this should be the first investigation in any anemia patient who is approaching to us, so that we can have a holistic approach in these patients. So I am giving you the values. Hemoglobin is 6, TLC is normal, platelets are normal, slightly on the higher side. Smear is showing microcytic hypochromic picture reported by pathologist, and reticulocyte count is low, 1.5%. So what are the possibilities here? So you are dealing with a microcytic hypochromic anemia. So we have 3 differentials, especially iron deficiency anemia, thalassemia trait, and anemia of chronic disease. Thalassemia trait is usually mild. Anemia of chronic disease can be moderate. Also, iron deficiency anemia can be from mild to very severe. So we have to look at CBC parameters, and we have to look at iron studies, fasting iron profile, and serum ferritin. So look at this, this is the patient's values. MCV is 70, MCH, MC, SC are reduced, 28 and 23 and 28. RDW, red cell distribution width is quite high, 20. Ferritin is low, transferrin saturation is low, serum iron is low. And typical picture of iron deficiency anemia is there. So this patient is suffering from iron deficiency anemia. How to differentiate it from thalassemia trait is very important, because thalassemia trait patient presenting with microcytic hypochromic anemia and hemoglobin of 8 or 9, they are being treated with iron without going for further investigation for months and months, and that leads to iron overload and unnecessary treatment. So we can see that here also, again, the values of MCV, MCS, MCSC are almost similar. But if you see the RBC count, it is very high, 5.5 million in thalassemia trait, while it is only 3 million in iron deficiency anemia. And see the red cell distribution width. In iron deficiency anemia, it is very high, 20, while in thalassemia trait, it is only 15. And see the Menzer index. There are some of the indexes which can help. So Menzer index in iron deficiency anemia is on the more than 13, while in thalassemia trait, it is less than 13. Further, for differentiating between these three, you have to go for fasting iron profile and serum ferritin, which will definitely give you the answer. So ferritin values in iron deficiency anemia will be less than 10, while for inflammation and thalassemia, it can be normal or even on the higher side. You have seen the time of COVID and dengue and other inflammatory condition where ferritin can be there up to thousands. So whenever there is severe inflammation, ferritin will be very, very high as an acute phase reactant also, and otherwise also in these conditions it is high. So this is again case 1. So what further evaluation you will do, because your patient is iron deficiency anemia and you know that this is a pregnancy state, gravida 4. So here there is no further action is required, but otherwise in your any other patient who is having these parameters, then you have to look for stool local blood, you have to look for anti-gliadin antibody or anti-TTG, which will rule out the celiac, and you have also to go for upper GI, lower GI endoscopy based on the indication and age of the patient. These we should remember that it's not only important to diagnose the iron deficiency, but it is very, very important to know the underlying cause, which can be a very mild cause to a life-threatening malignancy, underlying colonic malignancy. So you see increased demand for iron and hematopoiesis is in the condition where there is a rapid growth, like adolescence and pregnancy. Increased iron loss, which can be chronic and acute, and chronic blood loss is most of the time it's not obvious. Even patient says stools are fine, I have not seen any bleeding manifestation, but we have to look for it. And then decreased iron intake or absorption is very, very important. And there are certain diseases like celiac disease and other diseases and surgeries, especially if the small intestine surgery, especially including jejunum or small intestine has been done, that is the site of iron absorption, will lead to refractoriness to oral iron, and recurrent anemia, iron deficiency anemia can be seen in the practice. Every year or 2 years, patient will be coming to you with iron deficiency anemia. So this is the case 2. The same type of female, 21-year female, non-pregnant is diagnosed. You have diagnosed the patient as iron deficiency anemia, and iron profile, everything has been done, and CBC parameters, everything is done. And now you have given her the iron, 200 milligram elemental iron, and hemoglobin rise only 0.5 gram after the end of 1 month. So what you will do is see the prescription of the physician. Tablet iron is 1 tablet twice a day, calcium is 1 tablet twice a day, pantoprazole 40 milligram, and Vicosol. So what is the wrong with this prescription? Yeah, so there are 2 things. One is a co-prescription of calcium with iron. Iron is not going to be absorbed. Second thing is, if you are not able to maintain the acidic medium in the stomach, again it is not going to be absorbed. So there are 2 things, calcium and pantoprazole. Although the physician has done it in the goodwill of the patient, but the main treatment is not going to work. You have to avoid calcium and PPIs and Gelusil and all those antacids when you are prescribing iron to the patients. So this is the case 3. 34-year male, again severe iron deficiency anemia, pencil cell, target cell, peripheral smear, MCV very low. Iron profile is suggestive of severe iron deficiency. Stool local blood for 2 days is negative. Physician has prescribed only iron, albendazole. Compliance is very good. Again, but the rise is only 0.5 gram after 1 month. So we say this refractoriness to oral iron because at least in 1 month, 1 gram rise should be there at the end of 1 month when your prescription is fine and the diagnosis is okay. So what is happening here? If you go for upper GI endoscopy, maybe you get a flattening or scalloping of duodenal mucosa. You go for D2 biopsy, you see this type of picture. So upper part is the normal, duodenal mucosa picture. But in the lower part, you see the pathological finding where crypts and villi, they are gone. It is just flattened. There is a lot of lymphocyte infiltrate in histopathological examination, very consistent with celiac disease. And if you do the anti-TTG, it will be positive in more than 90% of cases. And specificity and sensitivity of this anti-TTG, tissue transglutaminase is almost 90%. So celiac disease, iron deficiency anemia can be the only manifestation in 40% of cases with celiac disease. And it can constitute almost 5 to 6% of IDA cases. And in refractory anemia, iron deficiency anemia, not responding to oral iron, the chances of getting, diagnosing celiac disease is even high, up to 20%. Okay, and duodenal mucosa can be normal, so it cannot be ruled out by endoscopy, but definitely with anti-endomysial antibodies and all, we can diagnose this condition. Okay, so we should know what are the causes of refractoriness to oral iron. So incorrect diagnosis like thalassemia, as I discussed, non-compliance, co-prescribed medication like antacids, PPI and calcium along with iron, dietary factors like tea, coffee and food. If the patient is taking iron with coffee and tea, it's not going to work. Iron loss, ulcers, tumors, like that in GI tract, and then iron malabsorption, celiac disease and other conditions. Okay. So this is case for 60-year male presented with low-grade fever for 1 month, weakness and lethargy. So anemia is there, 2-unit PRBC transfusion history is there, no response to B12 and iron. He has already received in the outside consultation. Again, if you see the hemoglobin, it's 6, TLC plated normal, GVP microcytic hypochromic along with some normocytic normochromic cells. B12 is normal, folic acid is normal, ferritin is normal. On the higher side, iron, everything is normal, thyroid, electric cavity, everything is normal. See that there are miliary shadows in the X-ray. And the bone marrow biopsy by the time came, it showed granuloma in the bone marrow. So what is this condition? This is a disseminated tuberculosis. So diagnosis here is anemia of inflammation. Underlying cause is miliary tuberculosis. Mechanism is interleukin 6 mediated rise in hepcidin. Hepcidin again is one of the very, very important regulators of iron metabolism. When hepcidin is increased in the cases of inflammation, it causes blockage of release of iron from iron stores, as well as absorption of iron from the GI tract. And this leads to functional iron deficiency. So although iron stores are there, but body is not able to utilize in the presence of anemia of inflammation. So the causes can be infection, inflammation, or other autoimmune disorders, and the treatment is, along with iron, you have to give erythropoietin to utilize. Now coming to the macrocytic anemia group, so we know that this again as a case reports, case presentation, 65-year male, vegetarian, okay, presents with fatigue and dyspnea, no history of bleeding, fever, jaundice, 4-unit PRBC transfusion, mild splenomegaly is there, hemogram is showing severe anemia. Peripheral smear shows macrocytes and macrovelocites along with hypersegmented neutrophils. So here the PS examination report is very important for you because this will give you a correct, which direction you should go. Hypersegmented neutrophils very specific for, B12 folic acid deficiency. Reticulocyte count is 2%. MCV is 110. So we know normal MCV is between 80 to 100. 100 to 110 is macrocytic. Above 110 is megaloblastic. So here you can see that in this picture, this patient is having macrocytes and macrovelocites, hypersegmented neutrophils are there, Cabot rings are seen in peripheral smear, and Howell-Jolly bodies are also seen sometimes in peripheral smear. And a good pathologist will give you with this report and will tell that it is very suggestive of B12 deficiency. You can see the RBC graph downstairs. In downside, so you can see that the RBC distribution is very wide. So it's a very important thing. It's going way beyond 100 MCV, and there is a hump also on the downslope. So this tells that in this particular report which I have taken for you, it tells that there are a group of cells which are having MCV, which is on the lower side, and the group where MCV is on the higher side. And the mixed MCV is coming around 100. Otherwise, if you see, the MCV should come here around 110, 115, 120 like that. So this gives a clue that probably your patient is having dimorphic anemia. Iron deficiency is also existing along with the B12 deficiency. There are RBC, histograms which can help you. This is there with the CBC report. If you ask for this, they will give you with the MCV, MCH report. These histograms will also be there for WBC, RBC and platelets. And basically the interpretation of RBC graph is very easy. So here you can see the normal graph MCV is around 80. In an IDA, so in IDA it is somewhere around 60 or 70. In Thaltret also it is somewhere around 60 or 70. Only thing is that here the RDW in IDA is high, 20 as in the previous case I mentioned. Here it is around 15 or 16. So in thalassemia trait it is RDW is normal, almost 15 or 16. Here again you can see macrocytosis, MCV is going near 100. Here in cold agglutinin disease also because there are RBC clumps, so the MCV will be on the higher side. Here in megaloblastic anemia, you can see that the graph has shifted beyond 110. So it means most of the cells are macrocytic. So what is the differential diagnosis of macrocytic anemia, B12 folic acid deficiency, myelodysplastic syndrome, aplastic anemia, and inherited bone marrow failure syndrome? Once you have ruled out B12 folic acid deficiency, there will be a need of bone marrow evaluation in these patients. Autoimmune hemolytic anemia, marrow infiltration, liver disease, and hypothyroidism are also causes of macrocytic anemia. Okay, so this again same case continued. B12 came out only 68. So this rest everything is normal. Coombs is negative. Started on Vitcofol for 1000 microgram daily for 10 doses and then once a week. And so hemoglobin rise is there. After 2 weeks, you can see hemoglobin from 7 to 9.5. Patient is responding, and this is B12 deficiency. So B12, the stores in body are very limited, 2 to 3 milligram. Although the requirement is also very less in the micrograms, and this is well maintained in the body because of the enterohepatic circulation. But those who are strict vegans or those who have some of the gastric problems like pernicious anemia, atrophic gastritis, old age, surgery, gastric surgery, ileal resection, these are the persons who are more prone for developing B12 deficiency. What can be the sign and symptoms? It's very varied. Like Boss has mentioned in his presentation also. So you can see low-grade fever can be a very common manifestation of B12 deficiency. You can have hyperpigmentation in the knuckles. I already mentioned in the picture, glossitis and all. Jaundice can be there as a presentation. And pancytopenia can be there in almost 60% of patients of B12 deficiency. So one of the very common causes of pancytopenia. And we have also reported, acute psychosis in patients with B12, acute psychosis. So many psychiatric manifestations. Almost 1/3 of B12 deficiency patients, they consult psychiatrist because of depression, irritability, and sometimes acute psychosis. Well, how will you diagnose? So cobalamin levels are there. If it is less than 200 picogram, it's definitive diagnosis. 200 to 350, it's subclinical. There you have to prove with other things like you go for a homocysteine level. If it is elevated along with B12 borderline, you can say that still this patient is having B12 deficiency. Okay, methylmalonic acid also will be elevated, although it's not available most of the places, but homocysteine is very easily available. So a combination of cobalamin plus homocysteine, even in borderline cases, will give you a definitive diagnosis that this is B12 deficiency. And once you start B12, the changes are very fast. So megaloblastic changes will improve within hours. So today you give B12, tomorrow you do bone marrow will be normal. It will not show any megaloblastic changes. So that's why whatever you have to do before giving Vitcofol. So sending B12 levels, doing marrow, that has to be done before giving B12, not after that, because B12 will come in thousands after single dose of B12 injection. Okay, anemia will take months to improve, hypersegmentation will take almost 2 weeks to improve. Case 6, again 56-year-old male, fatigue and dyspnea, no bleeding, no fever and all. Vegetarian by diet. Here hemoglobin is 8, again macrocytic and macroevelocytes are there, but there are hyposegmented neutrophils here, not hypersegmented. And there is macroevelocytosis. MCV is in the range of 106. So again, this is macrocytic anemia, but here the scenario is different. So you can take this as a evidence of dysplasia. And if you do the marrow iron stores, you will get ring sideroblast. Iron staining on the bone marrow cells. So this is myelodysplastic syndrome. It will not respond to B12. Initially we give a trial of B12 for 10 or 15 days, but if your patient is not responding, always think of underlying myelodysplastic syndrome as a possibility and send on higher center for bone marrow, and because the morphology in myelodysplastic syndrome is very, very important to interpret. Okay. Now coming to the normocytic normochromic group. So you can see the causes. This is the vast majority of cases which lead to normocytic normochromic anemia, autoimmune hemolytic anemia, membrane disorders, enzyme disorders, marrow failure, infiltration. So hematological malignancy, all leukemias and aplastic anemia, everything. It will be either normocytic normochromic or on the macrocytic side. Renal disease, liver disease, and endocrinopathy, hypothyroidism, and other additions disease and all will have anemia which is normo to macrocytic. So this is case, 48-year male, progressive fatigue dyspnea for 3 months, back pain is there for 3 months, which is very ignored symptom actually. Patient rushes to orthopedician and then taking multiple consultation before coming to the higher center. Hemoglobin is 6, MCV is 99. Okay, what you see in GVP normocytic normochromic picture, reticulocyte count is 1%. 2-unit transfusion, iron folic acid, no improvement. Okay, again hemoglobin is 7, TLC platelet is normal. You can see very subtle changes, not subtle, it's obvious, but can be missed. Rouleau formation is there. So this has to be picked up. So here it is rouleau formation, reticulocyte count is low, mild renal dysfunction is there. And if you do the bone marrow, you'll get plasma cells. So this is a case of multiple myeloma. Normocytic normochromic anemia, back pain, rular formation is there in peripheral smear, very important clue, and you do bone marrow, you diagnose a patient with multiple myeloma. Okay. Now coming to the very big group of disorders, hemolytic anemia. This is a very big group, so I'll discuss only few cases regarding this. So we know that the defect can be intrinsic to the RBC. It can be in the membrane, it can be in the enzymes, it can be in the hemoglobin formation, so thalassemia, G6PD deficiency, and hereditary spherocytosis. It can be extrinsic to RBC. So it can be autoimmune hemolytic anemia where antibodies are attacking RBCs, causing destruction of RBCs, or microangiopathic hemolytic anemia where there is mechanical damage to RBCs. And then rarely it can be acquired hemolytic anemias which are clonal, like paroxysmal nocturnal hemoglobinuria, PNH, a very rare disorder. So these patients, when they have acute hemolysis, they will present with back pain, abdominal pain, cola-colored urine, jaundice, pallor, and breathlessness. If it is chronic hemolysis, like in thalassemia, sickle cell anemias and all, mild to moderate anemia, gallstones, symptomatic splenomegaly, leg ulcers, bone pains, and skeletal abnormalities can be the manifestation. Okay. So physical examination will get splenomegaly, hepatomegaly, and peripheral smear examination is very, very important. So I'll go through some of the cases. So here is the case. Obvious here. What are these cells? These are spherocytes. No central pallor, small cells, smooth, small cells, but no central pallor is there compared to these cells. So there are spherocytes. When there are spherocytes in peripheral smear, think of two possibilities. Autoimmune hemolytic anemia, do Coombs test. Coombs test positive, this is AIHA. Coombs negative, look for hereditary spherocytosis. Go for osmotic fragility test. And then you can go for more refined tests like EMA binding test and RBC flow cytometry to confirm this, but you will have a very good suspicion on osmotic fragility test. So what is the clue to this spherocytosis in CBC report? If you see the mean corpuscular hemoglobin concentration, MCHC, it will be on the higher side. So in anemias, iron deficiency and others, you see that MCHC is going down, but in spherocytosis will go high because the RBC has taken such a shape that maximum volume can be accommodated in very small surface area. That is why it is getting oval or like a ball. Okay. Who is 36-week pregnancy, present with fever, headache. We just heard about headache in the previous talk also. Seizures. C. Fragmented RBCs. So this is microangiopathic hemolytic anemia. Look for reticulocyte, very high LDH, thrombocytopenia and anemia. Always, this is a medical emergency. You have to go for plasma exchange treatment in this because most likely possibility is TTP, HUS, thrombotic thrombocytopenia purpura. If available, we should go for ADAMS 13 levels, although this is a very high cost, but definitive diagnosis can be made. This is a case of anemia, history of transfusion, hepatosplenomegaly, 1-year-old boy, severe anemia. You can see there are a lot of target cells, nucleated RBCs, and anisopoikilocytosis again. So this is very suggestive of thalassemia. And age is 1 year, transfusion dependency is there, thalassemia major. And if you do the HPLC for them, you'll get only fetal hemoglobin. That will be 90-95%. There will not be any adult hemoglobin or maybe very, very minimal. So this is thalassemia major. This is very important. So always ask for a reticulocyte count. If reticulocyte count are high, like here you can see it is almost out of these 15 cells or 7-8 are having are reticulocytes. So very high reticulocyte count suggestive of hemolytic anemia. So this will help you in the direction which you should investigate your patient. Last case is this. So you can see again 5-year girl from Bihar, Jharkhand, presented with fever off and on, rash all over body, and bluish discoloration of fingers, especially at the end or the beginning of the winter season. And you can see the RBC. These are RBC agglutinates, RBC agglutination. Your pathologist can report to you. And this is most likely a cold agglutinin disease. It's a cold type of autoimmune hemolytic anemia. So our investigation, these are the outside investigation, and when we did the investigation, direct Coombs test is positive. Positive for complement by monospecific Coombs you go, it will be for C3. So warm AIHA are positive for IgG, cold AIHAs, cold agglutinin disease positive for C3. So this is cold agglutinin disease. Here the treatment of choice is warm environment, and steroids are not going to work here. You have to use rituximab for these patients if they are symptomatic. Fever is there, possibility of mycoplasma will be there. You have to use antibiotics against mycoplasma for early and fast recovery. So in summary, I just want to say that the initial investigation in any patient with anemia should be CBC, RBC parameter with RBC parameters, which obviously you are going to get. If its histogram is there, it's also very helpful for you. Peripheral smear examination and reticulocyte count with calculation of reticulocyte proliferation index (RPI). This is very, very important when we are evaluating or approaching a patient with anemia. And always search for underlying etiology. Diagnosing anemia and cause of anemia is not enough. What is the underlying etiology behind that, which can be a very simple cause, it can be a life-threatening cause. That effort should always be made, especially in the cases of iron deficiency anemia, where it can be a colonic malignancy, it can be just like decreased iron intake in the food. So any cause can be there. So with this, I would like to thank you for patient hearing.
Please, Dr. B.K. Misra sir. Dr. Anurag Varma sir. Sir, please. Thank you.